Welcome to the deep dive. Today we're aiming for, well, total mastery over a disease that's ancient, widespread, yet often hidden.
That's right. We're diving deep into female genital tuberculosis,
Yeah,
FGT.
exactly. And the sources we're using demand more than just a quick overview. We need that deep, professional level understanding, elite, really.
Absolutely. Because FGT, it's not usually the first thing people think of with TB, is it? Everyone focuses on the lungs.
Right. But this form, genital TB, it's fascinating pathologically
Yeah.
and devastating.
It really is a classic stealth disease, and to master it, you have to go back, way back.
Centuries, apparently.
Yeah.
Which is kind of mind-blowing.
It is. The first really solid description, 1744, an Italian anatomist, Margani.
Morgana. Okay, what did he find?
He did an autopsy on a young woman, only 20, who died of generalized TB, and he noticed her uterus and, crucially, her fallopian tubes. They were filled with this weird, yellowish, cheese-like stuff.
Caseous material, even back then.
Exactly, the hallmark, long before anyone knew what caused it.
Which took until Robert Koch, right,
Yep.
1882.
That was the breakthrough. Koch identifying Mycobacterium tuberculosis. That changed everything for public health.
So after Koch, things started improving, at least in some places.
Definitely. In Europe, America. Developed countries saw a pretty sharp decline starting in the early 20th century. It actually became quite rare, still is, relatively speaking.
But relatively is the key word there, because globally, it's a whole different story.
Completely different. It's still rampant, endemic in many developing countries, Latin America, Asia. India gets mentioned specifically as highly endemic.
And even in developed nations, it hasn't vanished and pops up in certain communities.
Yes, often among immigrants from endemic areas like Asia or Africa, and sometimes in inner-city communities with specific vulnerabilities, you still have to be vigilant.
Which brings us to the diagnostic challenge, the stealth disease aspect. Why is it so hard to pin down the actual numbers?
Because so many patients have no symptoms at all. Maybe 10, even 15% are completely asymptomatic.
Wow. So how is it usually found then?
Often, it's an incidental finding. A woman comes in for infertility investigations, maybe chronic pelvic pain, and then they discover the TB.
Which leads us to some pretty stark statistics. Schaefer's work from 1970.
Yes, that was seminal. He found that among women dying from pulmonary TB, somewhere between 4 and 12% also had genital involvement, often completely unsuspected during life.
4 to 12% is huge for a secondary site. And the link to infertility, that seems to be where it really hits hard clinically.
That's the #1 reason this needs mastering. Globally, maybe 5 to 10% of women seeking help for infertility have FGT, but in those endemic zones.
The numbers jump dramatically.
Oh, absolutely. New Delhi reports of 9.3% among infertility patients. Mumbai, even higher. Some studies found rates from 13% up to a, frankly, shocking 39% in women specifically going for assisted reproduction.
39% in an IVF population. That's staggering. That demands suspicion, doesn't it?
It absolutely mandates it. Clinicians in those areas have to have FGT high on their list.
And demographically, who are we mainly talking about?
Classically, it's seen as a disease of young women, reproductive age. About 80% diagnosed between 20 and 40.
Peak fertility years.
Yeah.
Makes sense given the infertility link.
But it's not only young women. Falk in Sweden reported about 16% of his cases were over 50, around menopause. So it can reactivate or be found later, too.
Okay, that sets the stage really well. Let's dig into the how. Pathogenesis. How does it actually get established in the genital tract?
Right. First, the culprit. Mostly, like 95% of the time, it's M. tuberculosis, the usual suspect.
And the other 5%?
That's typically M. bovis, the bovine form. You see that more in places without good cattle control or routine milk pasteurization.
So unpasteurized milk or infected meat could be a source.
Exactly. If a country doesn't pasteurize, the risk of M. bovis causing genital TB is higher, and finding either one.
Yeah.
You still rely on that classic Ziehl-Neelsen acid-fast stain.
Got it. Now, the crucial point you made earlier, it's almost always secondary.
Overwhelmingly so, like 99% of cases. The primary infection happens somewhere else, usually long before.
And where's that primary site typically?
Lungs are #1, about 50%. Lymph nodes are a close second, maybe 40%.
Okay.
After that, you might see kidneys, joints, the gut, or sometimes it's a miliary infection spread widely.
So if the primary is often the lung, how does it make the journey down to the pelvis?
Primarily, it travels through the bloodstream, hematogenous spread.
Makes sense. The bacteria get into the blood.
From that initial focus, and they circulate, eventually seeding the pelvic organs. The blood supply there is very rich, especially in the tubes.
So the bloodstream is the main highway. What about other routes? Lymphatics, direct spread.
Lymphatic spread can happen, but it seems less common for FGT. Direct extension, like from infected peritoneum right next door, that's considered pretty rare. Blood is definitely the dominant route.
This is where it gets really interesting pathologically. The dormancy. Infection happens in childhood, maybe unnoticed.
Exactly. A minor lung infection, perhaps. The body controls it, but doesn't fully eliminate it. Dormant foci remain silent.
For years, potentially.
Often for years, until puberty.
Menarche.
What happens then?
That's the trigger. Puberty means active growth, hormonal changes, and critically, a massive increase in blood flow to the genital organs, especially the tubes.
Ah, so that increased vascularity and hormonal milieu, it wakes up the dormant bacteria.
That's the prevailing theory. It provides the right conditions for those sleeping bacilli to reactivate and establish active disease. The reproductive system essentially kicks it off.
Fascinating. And once it's active, there's a clear pattern, right? The descending infection.
Precisely. This explains why the fallopian tubes are almost invariably the first place hit. Some surveys say 100% involved.
Always the tubes first. Why them specifically?
Their lining, the tubal mucosa, seems to be the most favorable nitises, the perfect landing spot for bacteria arriving via the blood.
And because it's blood-borne.
It's usually bilateral. Both tubes get infected. From there, it spreads downwards, descending. So tubes first then.
Then to the endometrium, the lining of the uterus. Then maybe the ovaries, the peritoneum around the organs. Vulva and vagina are typically last, secondary to spread from the uterus. It follows a cascade.
Okay, that covers the 99%. What about that tiny fraction, the 1%, where it's actually primary genital TB? Starts right there.
Very rare. Usually affects the lower tract, vulva, cervix. The source has to be external in those cases.
External. Like how?
The main suspect is the male sexual partner. Tuberculosis has been found in the semen of men with urogenital TB.
Right.
Another possibility mentioned, though maybe less common, is saliva used as lubricant if the partner has active pulmonary TB. Direct inoculation.
Adds another layer. Okay, let's zoom right into the cellular level. What happens when the bacteria lands? How does that classic TB lesion form?
Initially, it's just a general inflammatory response. Polymorphs rush in. But quickly, within maybe 48 hours, mononuclear cells take over, macrophages.
The bacteria like living inside those.
They replicate intracellularly? Yes. Then the body's cellular immunity kicks in. It tries to kill the bacilli, but the process itself causes damage. That's where you get caseation necrosis.
Caseation necrosis. That cheese-like dead tissue again.
The defining feature. And around this necrotic center, the body builds a wall, the granuloma.
What's the structure of that wall?
It's quite organized. Right around the caseous center, you have epithelioid cells. They're activated macrophages. And these large multinucleated lands, giant cells.
What do?
They try to engulf the debris and bacteria. Then further out, you get lymphocytes, monocytes, and fibroblasts trying to contain the whole thing. It's a battleground, walled off. That structure is the absolute hallmark you look for under the microscope.
Yeah, fascinating destructive process. Okay, let's map this onto the anatomy. Detailed genital tract lesions.
Yeah.
Where does the damage show up most?
If you look at the big studies, like Schaefer's, Nogales-Ortiz's, the hierarchy is clear. Fallopian tubes, 90 to 100%. Way out in front.
Always the tubes.
Always. Endometrium, 50 to 79%. Ovaries, maybe 11 to 30%. Cervix, lower, 5 to 25%. And then vulva and vagina, really rare, less than 1%.
So focusing on the tubes, the crucial site, bilateral hematogenous spread, what does it look like grossly? Early versus late?
Early on, the tubes might just feel a bit thick, maybe rigid, like a whipcord. You might see tiny white specks, tubercles on the outer surface. That's exosalpingitis.
Okay. And as it progresses?
Then you get the really destructive changes. The tubes dilate, get distorted. The outside becomes rough, covered in adhesions binding them to everything nearby.
Are there specific shapes or appearances we should know?
Yeah, sometimes they become elongated, twisted into a retort shape like lab equipment. That's seen in maybe 20% of cases.
Retort shape, okay.
But the classic, highly specific sign is the tobacco pouch appearance.
Tobacco pouch. How did that happen?
The main part of the tube, the ampulla, becomes massively dilated. But weirdly, the very end, the fimbriated end, which usually closes off in other infections, it often stays open, pouting, like the drawstring opening of an old tobacco pouch.
That's incredibly specific. What's inside that dilated tube?
Could be that typical yellowish-gray caseous stuff. or fluid, that's a hydrosalpinx.
Yeah.
It's blood, a hematosalpinx. If it's frank pus, a pyosalpinx.
And leakage causes problems.
Definitely. Paratubal abscesses, generalized peritonitis, fluid buildup like ascites.
And what about Fitzhugh-Curtis syndrome? I usually associate that with PID.
You can see it in FGT too. Those violin string adhesions between the right tube or liver capsule and the liver itself. If you see that in the context of pelvic disease that isn't responding like typical PID, TB should be on your mind.
Microscopically, the damage goes right through the wall.
Yes, transmural granulomas, that explains the permanent damage. And another key microscopic finding is reactive adenomatous hyperplasia. The lining of the tube, the endosalpinx, undergoes this crazy overgrowth because of the chronic inflammation. It can look so wild it actually mimics adenocarcinoma, a major diagnostic pitfall.
Wow. And that hyperplasia links to ectopic pregnancy risk.
Yes, that pattern, along with the scarring, is associated with a higher chance of ectopic pregnancy later, even if the infection is treated.
Okay, moving down to the uterus. Endometrium involved in 50–60%. But you said it often looks normal.
Grossly, yeah. Because the endometrium sheds every month with menstruation. The infection comes down from the tubes, hits the corneal ends first, forms little tubercles, but the superficial ones get shed.
Ah, which is why timing for biopsy is so critical.
Exactly. You need to sample late in the cycle, just before menstruation starts, day 21 to 26, ideally, or right at the onset. That gives the lesions time to develop before they're potentially washed away.
Does the infection persist then? How?
The thinking is the basal layer, the part that doesn't shed, gets repeatedly reinfected from the tubes. So it's this ongoing cycle.
What happens in severe, long-standing cases? What does the inside of the uterus look like?
You can get significant fibrosis. The cavity might become smooth, scarred, non-responsive. If you try to do a D&C, you get hardly any tissue back.
And visually, with hysteroscopy.
You might see that classic golf hole appearance. The openings of the fallopian tubes into the uterus look recessed, narrowed, weirdly round because of scarring at the corners.
And the ultimate consequences of uterine damage, scarring and blockage.
Right. Two major severe outcomes. Pyometra pus trapped in the uterus because the cervix is blocked. That happens in maybe 2 to 5%.
Okay.
More commonly, you get intrication adhesions. Scar tissue forming strands, bands, sometimes completely obliterating the cavity. That's Asherman syndrome.
And that directly causes menstrual problems, like amenorrhea.
Exactly. Destroys the functional lining. Leads to scanty periods or no periods at all.
What about the ovaries?
Yeah.
Involved 20–30%, mostly affected from the outside.
Mostly periophoritis, yes. The ovary itself isn't primarily infected. It's just encased in adhesions spreading from the infected tubes next door.
So true ovarian TB with granulomas inside the ovary is less common.
Much less common. That would require direct hematogenous spread to the ovarian tissue itself.
Okay, let's cover the rarities down below. Cervix, vulva, vagina. Cervix is 5–15%. What are the signs?
Often no visible signs at all. That's key. But sometimes it can look like a polyp or hypertrophic, overgrown. It can mimic cervical cancer, so biopsy is absolutely essential.
Any specific symptoms if the cervix is involved?
Maybe a yellowish-brown, offensive discharge, bleeding easily. And remember, primary infection from a partner is possible here.
And vulva vagina, less than 1%. How does it get there?
Usually direct spread downwards from the uterus or external inoculation like from sputum or a partner with TB elsewhere in the urinary tract.
What do those lesions look like?
Typically discharging ulcers, chronic sinuses, or sometimes nodular hypertrophic growths. There's even a severe form causing an elephantiasis-like swelling of the labia minora due to lymphatic blockage.
And these lower tract lesions, more common with HIV.
Yes, the HIV epidemic has definitely favored an upsurge because of weakened immunity and complications down there. Ulcers can heal with fibrosis, causing vaginal stenosis. Very rarely, a fistula like rectovaginal might form.
That covers the where and what of the damage. Now, how does the patient actually present? Clinical features.
And here's the paradox again. Up to 15% have zero symptoms. Some might have even had children before the TB really took hold or was discovered.
So you can't rely on patients reporting symptoms. You need red flags. What are the top ones?
Okay, the big five are 1, infertility, primary or secondary. 2, menstrual irregularities. 3, abdominal pain, often chronic. 4, vaginal discharge, persistent. 5, an abdominal mass you can feel.
Any general symptoms, too?
Sometimes, yeah. Low-grade fever, maybe night sweats, weight loss, just feeling generally unwell, fatigued. Things that suggest a chronic infection.
Infertility is the dominant one, though. 35 to 60%.
By far the most common reason they seek help. And usually it's primary infertility they've never conceived. About 75% of infertility cases presenting with FGT are primary.
And that's due to the tubal damage, the Ashermans.
Primarily, yes. Irreversible tubal blockage or damage, endometrial scarring, less often direct ovarian damage. And a huge clue. Ask about past TB history or contact. About half these patients have one or the other.
Menstrual irregularity is next, 10–40%.
Yeah.
Does the type of irregularity tell us anything?
It can vary wildly. Heavy bleeding, menorrhagia, scanty flow, hypomenorrhea, no periods at all, amenorrhea if the damage is severe or there's Ashermans. Even postmenopausal bleeding can occur.
Is there a geographical pattern to the type of bleeding?
There seems to be. In Western countries, maybe dysfunctional bleeding patterns are more noted. In places like India, scanty periods or infrequent periods, oligomenorrhea seem more common. The thinking is that might be linked to a higher rate of associated lung TB in those populations.
Okay, let's talk abdominal findings. The pain.
Often it's a chronic, dull ache in the pelvis. Sometimes it gets worse just before the period.
And finding a mass on examination, what could that be?
Could be several things rolled into one inflammatory lump. Thickened, rolled up omentum, loops of bowel matted together, trapped fluid, a pyosalpinx, or even a pyometra if the uterus is involved.
Is there a specific feel to the abdomen that suggests TB?
Yes, that classic doughy feel.
Yeah.
If you palpate the abdomen and it has that soft, indistinct, boggy resistance, that's highly suggestive of tuberculous peritonitis, a really important physical sign.
And the connection to PID that doesn't get better.
Crucial point. If you're treating someone for pelvic inflammatory disease and they just aren't responding to standard antibiotics or the PID keeps coming back, you have to think TB, especially in young, unmarried women presenting with a pelvic mass thought to be inflammatory. Suspect TB first.
Lastly, the complications if pregnancy does occur after treatment.
It's incredibly high risk. Ectopic pregnancy happens in up to 50% of conceptions post-FGT. The tubes are scarred just enough to let sperm in, but not enough to let the embryo travel back to the uterus.
50% ectopic, that's huge.
It is. And fistula formation, while rare, can happen usually after surgery on infected tissue, like draining an abscess.
Okay, given how sneaky this disease is, investigations are key. How do we find this hidden enemy?
You start broad with nonspecific tests. A CBC might show high lymphocytes, lymphocytosis. ESR, the sedimentation rate, is often high, showing inflammation, but again, not specific.
CA-125.
Can be raised too, but it's notoriously nonspecific for pelvic inflammation of any kind.
What about the Mantoux test, the skin test?
Still fundamental. It's positive in over 90% of FGT cases, showing past exposure. A negative Mantoux makes TB much less likely.
Is it definitive, though?
No, because it doesn't distinguish past exposure from active disease. And BCG vaccination can cause false positives. The quantiferon blood test is better now, more specific, less affected by BCG.
Moving to imaging. Hysterossalpingography, HSG, often used in infertility.
But TT, and this is a huge, but you should not do an HSG if you actually suspect active genital TB.
Why not?
Because injecting the dye under pressure can literally flush infectious material out of the tubes and into the peritoneal cavity. It risks spreading the disease, big contraindication.
Okay, but if HSG was done, maybe before TB was suspected, what classic signs would you see?
You'd look for specific tubal abnormalities, rigid, straight tubes with no peristalsis, the classic lead pipe appearance.
Oh, pipe, okay.
Irregular outlines, maybe beading along the tube, calcification spots, blockage right where the tube meets the uterus, the cornual end, a fuzzy, jagged appearance to the lining. And of course, that tobacco pouch look if there's a hydrosalpinx.
What about the uterus on HSG?
You might see an irregular cavity shape, filling defects suggesting adhesion signs of Asherman syndrome.
Ultrasound, useful for seeing masses.
Good for detecting masses, yes. Shows size, location. But US can't tell you what the mass is. It looks nonspecific. Its main role is often guiding biopsies like an ultrasound-guided fine needle aspiration or core biopsy of an adnexal mass or peritoneal nodule. Get tissue for testing.
Right, tissue is key. What about looking inside directly, hysteroscopy?
Essential for the uterine cavity. You can directly see adhesions, scarring, partial obliteration. You might spot those gulf hole tubal openings or even small ulcers.
But for the overall pelvic view, laparoscopy is the gold standard.
Absolutely. Diagnostic laparoscopy lets you see everything. You look for those telltale miliary tubercles, tiny white seeds on the peritoneum, bowel surface, omentum, outside of the uterus and tubes.
And you can see the state of the tubes directly.
Exactly. Thickened, rigid tubes, adhesions, maybe a frank pyosalpinx, and critically, you can take targeted biopsies of any suspicious lesion you see. That gets you tissue for histology and molecular tests.
Which brings us to tissue sampling and the modern molecular diagnostics.
Yeah.
Endometrial biopsy timing. We covered that. Late premenstrual.
Crucial timing. Get the sample, then divide it. Part goes for histology, looking for the classic granuloma with caseation. Part for traditional culture and AFB smear, though culture takes weeks and smears are often negative.
And the third part for the faster tests.
Yes, for PCR, polymerase chain reaction. That's the game changer for speed.
How fast is PCR? And how reliable?
Results within 24 hours, usually. It's highly sensitive, highly specific for detecting the mycobacterial DNA. Huge advantage.
But not perfect.
Not perfect. You have to be aware of false negatives, maybe around 8%. And importantly, false positives reported rates can be 10, even 20%.
20% false positive. That's significant.
It is. So a positive PCR needs clinical correlation. Does it fit the picture? Do you have histology to back it up? You don't want to treat someone with toxic drugs unnecessarily based on a sole PCR result.
Are there even faster tests now?
Yes. Innate nucleic acid amplification technique can give results in just a few hours. BACTEC is a rapid culture method, faster than traditional, maybe 5-7 days. And GenExpert is a PCR-based system that's also fast and can simultaneously check for drug resistance, particularly rifampicin resistance.
Okay, lots of tools. But FTT mimics other things. Let's quickly cover the differential diagnosis. What else looks like this?
Big overlap with regular pelvic inflammatory disease, PID. Both cause pain, infertility, discharge.
So how do you tell them apart?
The key is treatment response and recurrence. Standard PID should get better with antibiotics. If it doesn't, or if it keeps coming back again and again, think TB. That's the clinical pearl.
What about pelvic masses? Could it be an ovarian cyst?
Yes. TB masses can mimic ovarian cysts, broad ligament cysts, collections of fluid. The differentiator is often fixation. TB masses tend to be fixed, stuck down by adhesions. Cysts are usually mobile. And again, history of TB elsewhere helps.
Acute pain, missed period, adnexal mass.
Ectopic pregnancy. Always rule that out first. Urine pregnancy test, ultrasound with Doppler, maybe urgent laparoscopy. It's an emergency.
Cervical lesions mimicking cancer.
Yes, we mentioned that. Ulcers, growths, visually indistinguishable sometimes. Biopsy is the only way to know for sure. Cancer versus TB.
Any other granulomatous diseases?
Less common, but yes. Certain fungal infections, sarcoidosis, they can form granulomas too. Needs careful histology and special stains. And down on the vulva, filariasis can cause swelling that looks like hypertrophic TB. Again, biopsy clarifies.
All right, diagnosis confirmed. Now the crucial part. Treatment, management, and prognosis. What's the first line?
Chemotherapy. That's the absolute mainstay. And usually, patients don't need hospitalization unless they're quite sick with fever, severe pain, or need something drained.
What's the standard drug plan?
It's the WHO standard short course category I regimen, 6 months total. Designed to be effective and, importantly, prevent drug resistance.
6 months. How is it structured?
2 phases. First, an intensive phase for 2 months. 4 drugs taken daily. Rifampicin, isoniazid, ethambutol, and pyrazinamide. RIPE.
RIPE for 2 months. Then
Then a continuation phase for 4 months, usually just 2 drugs. Rifampicin and isoniazid, often given less frequently, maybe twice or 3 times a week to help with compliance.
these are strong drugs.
Yeah.
Side effects must be a major consideration. Rifampicin.
Key things. Hepatotoxic, so monitor liver function tests LFTs before and during. Can cause a rash. Turns urine and tears orange, warn the patient. And critically, it messes with oral contraceptives, makes them less effective. Need alternative birth control.
Isoniazid. Also liver issues.
Also hepatotoxic, yes. And the other big one is peripheral neuritis, nerve tingling, numbness. Preventable by giving vitamin B6, pyridoxine alongside it. Standard practice.
And ethambutol. The eyes.
Optic neuritis is the risk. Can affect vision. So mandatory eye check before starting and careful monitoring during treatment. Any visual changes? Stop the drug immediately.
These risks underline why finishing the full course is so vital.
Absolutely, which is why DOTS, directly observed treatment strategy, is so important.
DOTS, where someone watches the patient take the pills.
Exactly. Ensures compliance. The results are dramatic. India's program using DOTS saw like an 86% success rate, huge drop in deaths. Non-compliance is how you get treatment failure and drug resistance.
What about those resistant cases? or patients with HIV?
They need longer treatment, different drugs. HIV co-infection often means Category 2 drugs for over a year alongside their HIV meds. Heart. Multi-drug resistant TB needs second-line agents. Capreomycin, kanamycin, ethionamide, tougher drugs with more side effects.
Given all the anatomical damage we discussed, is there a role for surgery to, repair things?
Generally, no. Surgery is really a last resort in FGT.
When would you consider it?
Only if the drugs aren't working progressive disease, persistent large masses like a piocell-pinx that won't resolve, maybe the fistula, but any surgery must be bracketed by chemo before and after.
Are there times surgery is absolutely contraindicated?
Yes. If there's active TB elsewhere in the body, or if there are extensive plastic adhesions involving the bowel, trying to dissect those risks serious bowel injury or fistula. Too dangerous.
And the really big surgical no, trying to fix the tubes for fertility. Tuboplasty.
Strictly contraindicated. Trying to operate on those scarred tubes often just reactivates the disease. And even if technically successful, the tubes are too damaged internally. Function cannot be restored. It doesn't work for TB.
So surgery is purely for removing persistent problems.
Essentially, yes. Removing a large symptomatic adnexal mass. Draining a pyometra. Maybe, very rarely, a hysterectomy with removal of tubes and ovaries if the disease is life-threatening and unresponsive to drugs. Damage control, not restoration.
This leads us to the bottom line, prognosis, especially for fertility.
And this is the really sobering part. The infection itself.
Yeah.
Highly curable with chemo. Maybe 90% cure rate for the TB bacteria.
But fertility?
Dismal, because the damage is done. The chance of conceiving naturally after FGT is incredibly low, only about 10%.
And if they do conceive naturally?
Huge risks. We said 50% ectopic pregnancy, another 20 to 30% miscarry.
So the actual chance of taking home a baby?
The bottom line from the sources is stark. Only about 2% of women with genital TB achieve a live birth. 2%. That number just lands with such weight.
Devastating. So for women wanting children, assisted reproduction is the main hope. IVF.
It's the main option, yes, offered after successful chemo. But even IVF success rates are lower than average for FGT survivors, maybe around 10%, according to some studies like Marcus's.
And that depends on the uterus being okay.
Absolutely. IVF needs a receptive endometrium. If the uterine lining is too scarred, too damaged from Asherman's, then even IVF won't work. Surrogate pregnancy might be the only path left.
Finally, follow-up. Is it lifelong?
Need close follow-up for at least 5 years, because reactivation is always a risk. Yearly checkups, maybe an endometrial biopsy annually or if symptoms recur, but definitely no HSG during follow-up, same risk of reactivation.
Okay, we've gone incredibly deep here. From Morgani's first glimpse of caseous material to the hematogenous spread, the dormancy, the fallopian tubes as ground zero.
Right, through the specific pathology, that tobacco pouch tube, the golf hole ostia.
The diagnostic challenges, the rigorous treatment, and finally, that heartbreaking fertility prognosis despite high cure rates for the infection itself.
I think the biggest takeaway for anyone listening, especially clinicians, has to be vigilance. Maintain a high index of suspicion. Chronic PID not responding. Unexplained infertility, especially primary. Think FGT. Assume nothing.
Because the consequences of missing it, particularly for reproductive health, are just catastrophic.
Absolutely. The silence is its weapon. Proactive suspicion is our defense.
So, wrapping this up, a final thought. We know this devastating pelvic disease almost always traces back to a primary infection, often pulmonary or lymphatic, caught in childhood, lying dormant for years.
It really makes you think, doesn't it? If we know the starting point is often treatable childhood TB.
Right. What if the focus shifted dramatically, if public health globally made the absolute, rigorous, fully compliant treatment of childhood TB the top priority?
Could we break that latency cycle? Could preventing and curing the initial infection in children fundamentally change the incidence of FGT for the next generation of women in these endemic areas?
Treating the child today to prevent the infertility and heartache decades later.
It feels like that has to be part of the long-term answer, doesn't it? A truly preventative strategy.
A powerful and urgent challenge. Thank you for navigating this complex topic with us. And thank you for joining us for the deep dive.